All right. Greetings, everyone. This is Eric Glazer. Welcome back to Bright Spots in Healthcare. We're produced by Bright Spots Ventures, and each week our mission is to spotlight what is working in healthcare and help scale it. And we do that by bringing together leaders across providers, plans, and innovative organizations across the country to share practical strategies, creating real world impact. Today, we're looking at something that most plans think about through the survey, but experience is a much more continuous way of doing it. We're calling this episode How Medicare Advantage Plans Are Rethinking CAHPS and the Member Experience. Now, back in September, me and my team were getting ready to go to Health, which is in Vegas in October. And I needed a new piece of recording equipment so I could run interviews from the media lounge in a simple way, connected to my iPhone. And I did some research, found a company with good reviews, simple setup, dummy proof for someone like me, ordered it, no problem. Everything looked like it was working. And then I received nothing. No shipping updates, no tracking, no clarity on when it was coming. Meanwhile, I've got Health getting closer and closer to D-Day. October's closing in, and I'm trying to figure out, did I miss something, or is this just not happening? So last minute, I go onto Amazon. I do get a backup piece of equipment. It wasn't great, but it got there in time and it did the job. But here's what struck me with all this. Everything looked like it was working, but the experience still failed. Not because of the purchase, not because of everything that came after it. Now, obviously, healthcare is more complex than a piece of recording equipment, but the dynamic is the same. Nothing's clearly broken, yet the experience still falls apart when the person on the other end doesn't feel guided, informed, or confident in what they're doing next. So in MA, Medicare Advantage, that may look like a member who gets their ID card but doesn't really understand their benefits. Maybe they get outreach, but they're not sure what to do with it. They see a provider, but they leave without clarity on what happens next. That's my mother right now. So over time, that's what defines the experience. It's not any single interaction, but whether the journey ever felt connected, right? And I think that's the challenge with CAHPS. It's not measuring a moment. It's reflecting whether all those moments actually come together in a way that worked for the member, worked for my mom. So that's what we're here to talk about today. That's how we've gathered this great group of experts in front of you today if you're watching on Zoom. And that's exactly why we've chosen MedOrion to be the sponsor and partner for today's conversation. They focus on helping all of you who are at health plans understand not just who to reach, but who is actually likely to act. And that will drive the action. Because at some point, this stops being about feedback and starts becoming about influence. And if you don't have a clear handle on how and when to appropriately engage members, you start to lose the ability to impact and engage them at all. And if you can influence those moments in real time, you don't just measure that experience, right? You change it. So if you want to check out MedOrion and how they could help you guys, go to medorion.com. We'll put the URL in the chat and in the show notes. It's MEDORION. All right, let's introduce this esteemed group, this highly curated group of experts who are going to share with you incredible ideas and bright spots. We'll start with the aforementioned MedOrion, Dave Brionic, who used to be at Anthem, used to be at Humana, ran corporate quality at those organizations. He's now the Chief Strategy Officer at MedOrion. So welcome, Dave. We have Dr. Daniel Knecht. He is the Chief Medical Officer and Senior Vice President at Emblem Health in New York City and Connecticut. It's not New Jersey, right? I can't say tri-state, right? Dan, I could just say Connecticut and New York, right? I want to say tri-state, but I won't. Stacey Friedman's the Senior Director of Quality and HEDIS Stars at Doctors Health Plans in Southern Florida. Paula Jackson is the Director of Quality and Population Health at Security Health Plan in Wisconsin, part of the Sanford Health Organization. Thank you all for being here. Let's jump right into it if we could stay on time. At the core of the conversation is this simplified but difficult question. If CAHPS is the output, what actually shapes the experience? that members are responding to. So, Dan, I'm going to start with you. At a high level, when do you think what do you think when you think about the member experience? Where are you seeing the earliest steps of friction or rising risk, and how are you guys at Emblem Health responding to all of that?
Yeah, absolutely. And first of all, Eric, thanks for the opportunity to speak with you all, and big fan of your broadcast at Bright Spots and Healthcare. It's a lot of great nuggets in there. So when you think about friction, the name of the game is trying to go upstream of friction and avoid friction, right? From reactive to proactive, to be predictive and personalized. And so we're on that journey, like many of health plans across the states. I think one example that really um, exemplifies where we're headed is our environmental resilience program. And so what we've done was, first of all, apply AI and machine learning to risk stratify our population. We also ingest real-time weather data and air quality data, and then ultimately layer on an AI agent called Rachel. And so what we were trying to do is to alert and keep our most vulnerable members safe as it relates to incoming heat waves, poor air quality events, and blizzard conditions. So this summer, we ingested weather data and identified an incoming heat wave. And what we did was we risk stratified our population based on comorbidities, social vulnerability. We actually looked at New York City heat vulnerability index data and identified those vulnerable folks living in zip codes which are defined at high risk of poor health outcomes as it relates to incoming heat wave. And so we then deployed an AI agent, Rachel, and Rachel called tens of thousands of Emblem members who are at risk for poor health outcome related to a heat wave. And so we educated those individuals on medication adherence, on keeping themselves safe as it relates to a heat wave, geolocating cooling centers, and frankly, educated them on pet safety too, right? Pets are a part of the family, really important to our members. And the idea was to empower our members in a very personalized way and prepare them for this incoming, frankly, natural disaster. These heat waves kill thousands of Americans each and every year. It's highly preventable. And so we launched that program this summer and really pleased to say that we had very good feedback from our members. And crunching the claims data, we were able to reduce ED visits and inpatient stays by almost 50% on those high heat days when we deployed this agent. So we also have Rachel working as it relates to poor air quality, blizzard. And actually, today, she's reaching out to those very members who are at risk for heat waves and educating them on the HEAP program and the opportunity to get a cooling benefit available for them based on their socioeconomic status. So I think it's a great example of how we're going upstream of risk, identifying those most vulnerable members, and then providing actionable, personalized recommendations and helping them stay out of harm's way.
Not to mention, you're also connecting in a very relevant way supplemental or core benefits that they may not know about, which I think is also has a lot of accretive value to whatever you invested to make this program hum, that I'm sure was more than paid for by the 50% reduction in ER visits.
Yeah, absolutely. And I think that the real technological unlock is the advanced analytics, and it's the new agentic AI, which we're able to really scale personalized outreach well beyond what our human care managers can do. And of course, we have a human in the loop. So in the event there's an escalated need, the AI kicks it over to our human care managers to sort of engage in a deeper level of engagement.
Gold. Incidentally, folks, you'll see us throwing in notes live into the chat if you're watching on Zoom. If you're not and you're just listening, I guess you lose out. But we are going to also create a key insight summary. We call it a kiss. You'll get a kiss from Nicole, our producer, after the show. Actually, I think it's going to come from me, but she'll produce it. And if you guys who are just listening want a copy of it, just request it through the link on the show description. But we'll send that all out to you so you get these great ideas summarized for you. Great job, Dan. Way to start us off. So that's an example of seeing something early and acting on it. And as those signals exist, I would suggest that probably some plans still struggle to translate that into action. So Dave, when plans do identify signals, where do you most often see them struggle to respond effectively? And maybe what's the approach to turning that around into positive action?
Yeah, yeah, and great question. And Dan, I thought that was really cool. Haven't heard of anybody doing, what you all are doing up there with the agentic AI and monitoring weather. And I have a daughter in New York that appreciates that for sure, as she's going through that. But so great question. And honestly, what we see most often really isn't kind of that data problem. I think a lot of plans have been working on data. Granted, you can always get better on it. But I'm going to get a little bit edgy here and call it really an execution challenge, right? An operational challenge. But before I get to kind of the places where we see folks struggling, I want to make sure we identify something that really underlies all of them, right? And I think it's what I'll call the shift, and it's a shift from monthly campaigns to real-time signal response. So, I think most of you all know that the health plans today are pretty much operating on a monthly campaign model, batch up their outreach, run a campaign, wait till the next month, do it again. It's structured, it's relatively easy to administer, and a lot of times from the clinical perspective, it ties to national awareness months, colorectal cancer month, American Heart Association month, so forth. It's logical. And I think for a long time drove solid improvement, and was starting to see, the plans were responsive. But, what needs to happen now and where the shift, is going along with, where Dan was saying is really to get to higher levels of impact, is really focusing on that real time, continuously monitoring the situational, the behavioral, and the clinical signals as they come in and respond in the moment. That shift alone changes everything downstream. Because when you're working off of last month's data, right, your sequencing's already stale, your member has already moved on, and any communication is no longer really relevant at that point. So, with that kind of as a backdrop, where we see, I think, plans struggle to respond is in three areas. One, there's no clear sequence. Two, the insights that don't translate into action. And then three, cross-functional misalignment. So, when I think about no clear sequence, plans identify the gaps, but then essentially dump everything on the member at once, right? The member gets overwhelmed, they disengage. So the plan sends more pushes and the member stays unengaged, but becoming more unhappy with all the communications, right? And then the plan ultimately says, and I've heard this recently over the last few months, well, this member hasn't engaged in X amount of time, so we're going to stop communicating with them. The cost there is not yielding any output. But the plans we see really succeed, stagger their outreach, vary the ask each time upon what the most pressing signal is. So, being able to help with your refill instead of sending the 8 gaps, hey, can we help with your refill? So the sequence should be driven by timing, signal first, then gap closure need, and you start with kind of that hardest to move triple weighted measures, not really the easy wins. So from a clear sequence standpoint, look at the signals, understand the signals, communicate based on those signals, and make sure it's prioritized, so that the member can act on it. Insights that don't translate into action, cognitively and emotionally, you can't really ask a member to do 5, 8 things at once, right? Share one discrete action. So, not here's all the open screenings, not let's focus on, 8 different things, but what's the one thing that needs to happen right now? So when a member already feels like you're not focused on what matters to the health, and when you're trying to check the box to increase gap closures, right, piling on really destroys that trust fast. And then from a cross-functional misalignment, and this is one that's really key, the outreach has to reflect the organizational priorities and the member needs, right? Time-sensitive things have got to be critical, like poly-ACH, poly-COB. They got to be at the top of the mind to react to now. then you can focus on your triple measures or even focus on the CAHPS content around the annual wellness visits. But really make sure that the whole organization is aligned with the communications that are going to the members. So bottom line, right, wrapping it all up, plans that make the shift from monthly campaigns to real-time signal response and prioritize those well, sequence thoughtfully, suggest one discrete action, and always offer to help, right, are going to see stronger engagement rates, lower member abrasion, and ultimately results that are going to be sustainable over time. So I don't see it as a data issue, right, that we're challenging with, but more of an execution, prioritization, and communication issue.
Good stuff. So the issue, Dave, isn't visibility, it's what happens next. And in many cases, that's where the performance slips. So I'm going to transition over to Paula Jacobson. She's the Director of Quality and Population Health at Security Health Plan. And Paula, when you looked at your organization's performance, what made you realize something needed to change, and how are you approaching the member experience, and how did you navigate all of this?
Yeah. As you said, when we looked at our CAHPS and our STARS performance, there was an obvious indication that we needed to do something for our Part D measures, which, as we know, encompasses some clinical, some member experience. And when we looked at that in detail, we realized there was a large part was due to a breakdown in the experience. It wasn't just, as has been mentioned, it wasn't what Dave said, just a metric thing. It was looking at that experience. And so on paper, we had some great programs, some resources. The right teams were doing the right things and getting information out to our members, but the experience was continuing to tell us, a different story in terms of our CAHPS scores. And so there was obviously a gap there in the value that we were offering to our members and either their understanding or their use of those benefits. And so they didn't understand them, that they were as affordable, or that they had the access, or we had the resources available to help them. So when we looked at that, we realized we needed to look at our communication. It was an issue. We needed to be broader and had to do some, integration, looking at the various departments, sort of as your original example, and, not just making sure each team separately is doing the right work, but making sure collaboratively that we're hitting the mark with our members. And so, as I said, each of the teams was doing the right work. We came together, took a strategic approach that shifted from that narrow, just looking at the survey mindset to really the member's journey and experience. And so we, integrated a plan with our marketing team, looking holistically at their experience, pulled together teams from the pharmacy, quality space, any of the departments that were impacting that we thought would be helpful. Came up with a strategic approach for the coming months, with targeted outreach, meaningful messages, really collaborating on that and framing that message towards education, awareness. What are the supportive services that we had? And we were able, through that integrated approach, bringing all of the teams together, making sure, as Dave said, that our messages were aligned. We were all swimming in the right direction, being consistent with our members. We were able to be really intentional with our approach and that member journey, and it did end up translating into improvement in our drug plan performance, an increase from 2 to 4 stars. So we were excited about that.
So the shift was from measuring the experience to actually designing it to be that was the key part. And so once we see those gaps, that I guess the next question is where we're going to focus. So I'll bring in Stacy Friedman. She's the Senior Director of Quality and HEDIS Stars down in Doctors Healthcare Plans in sunny Florida. So Stacy, once you see the gaps and the question then becomes the focus, when you came to the organization, where did you see the biggest opportunities to move performance forward?
So what I saw, obviously, when you're looking at the measures, you want to hit the ones that have the highest impact, those 3 weighted measures. And looking at our performance, our HEDIS performance was pretty good. Part D was not very good. So we were working on a historical star scores of like 2, 3, and 1 for all our medication adherence measures. And if we wanted to continue to move forward and get a 4, 4.5, and a 5 stars, we really had to focus on those measures. And so what we did is we reviewed our existing vendors. We're trying to consolidate, not have a million vendors doing single things, right? We want to have a vendor that's hitting multiple areas of the plan. So we have our one vendor who was also our infusion vendor and our DME vendor. Turns out they had a very robust home delivery program where they would deliver medications to the members at their homes. They were very sophisticated. They have an app. It's sort of like an Amazon kind of thing where you can see on a map where your driver is and when he's coming to your house. So we really kind of jumped in, and the pharmacy team and the quality team worked together to focus and pull members' attention to using home delivery. First of all, that helps with med adherence. If you know it's coming on a regular basis, then you don't have to worry about going to the pharmacy or missing that impact date, where if you miss it, then your PDC rate drops and you potentially are out of the measure for the rest of the year. So it was really a successful program. We used our HEDIS coordinators to go out to our provider offices. We did co-visits with the pharmacy delivery program managers, and we talked to providers about this option because we had a lot of providers not performing well with adherence, and they want to know how they can get better. So we did that. We started this in 2025. We did have some metrics in 2024 because, they were somehow people that had the DME and maybe infusion services knew about their home delivery program, but it was nothing that we were really marketing to our members. So once we started marketing to our members, making phone calls to members, in 2024, we went from 1,292 scripts filled at the home delivery program to, in 2025, we went to 4,422 scripts. So a very healthy jump in the number of prescriptions filled. Our medication adherence numbers increased. We went in 2024 measurement year for diabetes adherence. We went from an 85 to 2025. We are now at a 92%. And in 2024, we were at a 90%. And 2025, we were at a 95%. And then in 24 for cholesterol, we were at 83. And now we're at a 91. So we had some significant increases in our rates. And we are attributing to that's one of our core changes that we made in our program.
God, this is gold. I'm loving this. This is great stuff, Stacey. That's a great story. Again, we'll try to get some of this in the key insight summary. Nicole's typing diligently notes into the chat for everyone. That was gold. Thank you. We're doing a lot around this. I know with the final rate and rules notices and everything tied to the challenges you guys are facing with your government businesses. So I just want to give a quick heads up. Two things. One, we always ask for your feedback. I know you regulars know this. You're sick of me saying it, but everyone the team looks at the feedback. So we're going to send that to you at 45 minutes past the hour. We'll put it also in the chat about 45 minutes after the hour, and we'll get you guys your feedback so we could do things like what we're about to do, and that is register you if you want for our next relevant episode. And we have one on May 7th talking about HRA completion and converting that to actual clinical engagement and impact. And that's going to happen on May 7th, featuring, I think we'll have up to 3 health plans. We have 2, I think, tagged right now. It'll be a great episode. Looking forward to that one as a nice extension to this episode. If you want us to register you, let us know right there. The poll that just popped up, and we'll make that happen. All right, so we've talked about signals, and now we've talked about where execution could break down. So Dave, I want to bring you back in. Dave for ANOC, Chief Strategy Officer, Ryan. I got a 2-parter for you. So if you think about all the moments in the member journey, where do you see plans getting the biggest return from a relatively small number of actions, right? Like that simplicity strategy. And then once you answer that, can you walk us through an example of how a plan identified that moment and actually acted on it? Because it's easy to talk about, but it's really hard to do. So tell us what to think about, and then tell us how it was done.
Yeah, absolutely. And again, reinforce the whole, monitoring the signals, aligning on that, having an organizational alignment piece. But I think if we want to get really kind of focused, right, one of the single biggest opportunities that we see is really the ANOC process, right? The annual notice of change. So a lot of plans treat it as a compliance checkbox. You mail a 100-page document by September 30th, you're done. You did your legal thing. But think about what actually happened on the members' end, right? They received the document, they may or may not have read it, they may or may not have understand the impact to them, and they enroll or they re-enroll, even potentially passively. And then sometime later, they show up to use their benefits, and guess what? Something's changed. Their providers now, the network, their formulary has changed, their costs have gone up, co-payment, and they feel blindsided, right? And typically that happens right before the CAHPS survey. And that moment of surprise is really one of them that's the most predictable drivers of the negative CAHPS sentiment that we see. And the plan never saw it coming because they thought they fulfilled their obligation. Who sends out the ANOCs are not the same people that do the STARS work potentially. But at the end of the day, right, it doesn't have to be that way. So, there's a national Medicare Advantage plan faced the significant, benefit across about 100,000 Part D members, right? I know a lot of plans are going through that. They're not going to go through it again at the end of the year. So, instead of just mailing the ANOC, right, they used a signal-driven approach. They used multi-channel engagement program, around that to ultimately, look at the clinical signals, the situational, the behavioral that folks were going if they were going through the renewal process, to really personalize the outreach for every member. Yes, they sent out the document they had to, but they personalized it in additional communications by, who was engaging, who had the wellness visits on record, who were low utilizers, what was their language, the income, the access to barriers, the channel, and the message match to each of those individual profiles. So, they created a plain language call to action, look at your annual notice of change. Here are the things that are going to impact you. For those folks that didn't engage via the email, they engaged them with the bidirectional texting. And for about 30,000 members who engaged in that bidirectional texting, they could flag concerns that, there's that real-time almost dialogue, right? Did you read it? Do you understand it? Do you have any issues? Do you have any questions? And they also, allowed the ability to have members request help via that process. So, and where folks said, I really want to talk to somebody about this, the plan called them back within 24 hours. So, real-time response. And as a result, right, they saw about a 63% email open rate, which is typically double than the industry average out there. They had a great response rate of, I think, about 15% on the SMS side. They had a lot of those two-way conversations, and they had thousands of phone call follow-ups, right, for members who really needed to talk to somebody. And at this point, with CAHPS going on, the preliminary CAHPS scores also appear to be higher than expected, and higher than they had previously received. So while the news wasn't great, at the end of the day, folks got it, they understood it, and, they were reacting to it. So, to me, the bottom line is that while a member may not have liked those changes, they knew about them right in advance, and the plan was given credit for educating and informing. No surprises, no hiding behind the document. And, that journey shapes the outcome. So if you wait until a member has that bad experience, to start engaging, the damage is already done, and they're going to continue to look for ways of the gotchas at the end of the day. So, the ANOC, I think, and how it's approached is one of the clearest examples we've seen across any plan we work with on how you can, proactively work with members and start the year off right.
So if I could paraphrase that, you made a really good point there at the end, and I'm paraphrasing. I'm going to put it in the chat too if you approve it. Not that the plans aren't doing enough, that these efforts aren't always connected in a way that the member actually experiences. So that's the key. So if you can connect those, you're going to get maybe 60% or something like that. I mean, that's the key, right? To connect.
Yep. Right.
All right. So that's
Absolutely.
the Dave approved post there. I just did that live. All right. So, one of the things we actually did as we were preparing for today is we asked our friends at MedOrient to put together a short, I'll call it a companion piece for this episode, customized, called Redesigning Experience. We threw them a bunch of things we wanted to cover. And so we have a piece now that they offer where it talks about where the experience breaks down, how it's being shaped, not at that survey moment, but in those moments in between where members are just trying to figure out what's next. And it creates sort of examples and step-by-step on how to improve your ability to drive meaningful participation of your members in their care and in their benefits. So if you want this piece that we requested that they authored, calling Redesigning Experience, Nicole's going to drop a poll in there. I'll send it out to you. It's 7 pages, but it's only really 4. And one of those pages is a list. I'm big on lists. So it's a real easy read, 5-minute read. But it really breaks things down and maybe is a nice companion to everything we're talking about today. All right, let's bring in our favorite physician on the panel today and bring back Dan next. So Dan, sometimes it's not the tech, but it's integrating technology or augmenting technology that you have in your portfolio, like you did in that first example with the environmental issues, and then tying it to what I'll call in real life programs. So how are you building in New York a more continuous understanding of how your members, understanding of your members in general beyond those one-off moments using sort of in real life programs?
Yeah, no, it's a terrific question, and in a time where everything's more and more tech forward, digital, telephonic. Our leaders at Emblem Health strategically put a bet on the in-person will remain a very important component of improving people's health. And so more than 10 years ago, we set up a series of community centers called neighborhood care. So we have 15 neighborhood care centers across the 5 boroughs of New York, located in medically underserved areas. And really the idea here is to open up an easily accessible front door to health. And so these centers are staffed by very, say, high EQ, hospitality focused folks in the neighborhood care centers. And really what they do is they welcome in anybody in the community to our neighborhood care center. And we have a very robust set of programs ranging from Tai Chi to chair yoga, cooking classes, but also access to social work as well, and helping individuals navigate their benefits. And so I think most recently our CEO, Mike Palmetier, launched a $2 million food initiative where we're providing access to health for food across the city, including in our neighborhood care centers, because 1 in 4 New Yorkers are unfortunately struggling with food insecurity. Moreover, people, a really important statistic is that probably less than 1% of somebody's life is spent in a clinic or in a hospital. And that's a great thing, right? But life occurred, that 99% of life, we want to be there. We want to be a part of our members' lives. And so these neighborhood care centers can coordinate care. We can set up appointments for clinics. We can navigate and simplify health benefits, which, as we all know, can be very confusing and overwhelming at times. And we actually have our care managers piped into the neighborhood care centers as well to help with more clinical oriented questions. And so, it's more than a 10-year journey with neighborhood care, and we continue to expand. I think last year alone, we interacted with more than 30,000 New Yorkers looking for support in a multitude of ways. And so it's a really powerful capability for a regional health plan to sort of be in the community, engaging on a day-to-day basis. It really changes that relationship from sort of that point in time as it relates to a claim or prior authorization to really helping people longitudinally on their path to better health.
I like it. So it's that continuous shift from episodic to continuous. But I guess what matters is what the member actually is feeling and whether that experience makes sense to them. And that's a bit, you could do that through a neighborhood care program like that. I think that's super smart and interesting. I want to stay sort of in real life kind of lane for a moment and bring back Paula Jacobson. So Paula, can you give us a specific example of what you guys are doing and a change your team made and how you're engaging members and what actually happened maybe as a result?
Yeah. So we have continuously, over the last several years, had what we call our Medicare Academy. So, live sessions that are taped, and then we do have a resource library. And so that traditionally has been based on, somebody's interested in doing a presentation, great, we'll present. We did, with our integrated approach to our Part D improvement, decided that we wanted to integrate pharmacy and pharmacy-related topics into that strategically for the year. And again, looking through all the various departments and really collaborating. So even if it was a presentation, about falls prevention, covering some of the risk of some medications that are putting people potentially at high risk for falls, things like that. So we're really not just focusing on one topic, but embedding pharmacy into all of our topics whenever possible. And so we did that. We're going along really well. Our early CAHPS indicators came and showing that while we're giving the information, while we're doing that, we're really still seeing that we're not moving the mark. And getting needed medications was a particular area where has been frustrating for us. And so we quickly pivoted and worked with our marketing team, worked with our pharmacy team, pulled together resources. We're able to do some pharmacy-led webinars, get those out in our resource library that really spoke specifically to the resources, some of the programs that were available. We had, really positive response and continue to have positive response in terms of those going back to listen into those webinars. So it was really a collaborative approach, but it took several teams being able to have the capacity and the leadership support to say, yeah, we're going to pivot. We're going to accomplish this. It is something that takes priority, and we did see success in that.
Great. It's another great story. I love it. Thanks, Paula. So let's bring it back now. We've talked about how the experience is delivered, but another piece of this is helping actually members understand what to do next. I've alluded to that a few times now. So what Paula just described is important, but because it helps members understand what to do next. So Stacy, when you think about the member experience broadly, what do you believe Doctors Healthcare Plans is doing differently that members actually feel and react to?
So I think actually, we're doing a lot of things similarly to Emblem and Security, right? We're bringing our staff to our members. It's that personal touch that really matters. So if you're not familiar with the Miami market, we're 60% of our members are Spanish speaking, either some sort of Hispanic or Latin culture. Everybody at the health plan, I think I'm one of 3 people maybe that don't speak Spanish, but most positions require you to be bilingual so you can understand the culture and you can understand and talk to our members appropriately. And our call center is right here in Coral Gables. It's right in my office here on the other side. Our members know that when they call in, they're getting somebody that's in Miami, in South Florida, knows their challenges and understands their cultural differences. And our member service is accessible. One thing that is truly different is that we have members coming into our office that have questions. They can have EOB questions. They can have questions about prior auths. Our member services director is phenomenal. She is accessible to all of our members on first name basis with many of them, have cell phone numbers. She's constantly in the grind working with her team to help our membership. Our philosophy is very member centric. When our owners built this plan, they are a very family based oriented company. The company culture is like that. That's how we treat our members, and that's what we project out in the community is that your family, we want to help you. We're here for you. We've got case manager out in the field dealing with social determinants of health issues. We also have an APRN out visiting our homebound members who can't get to their provider offices. So, and this translates into CAHPS scores, right? So what we saw prior to the last 2 years, previous to that, our CAHPS scores were a little bit lower than we wanted them to be. And, we really started focusing on how we can address these. And that member detail and that member attention, we went from 3s and 4s to last year, we were 5s and every single CAHPS measure, well, I say except for flu. I don't really count that one anymore because most plans probably don't. And this year we're trending in the same place. So it really pays in a way, and as far as CAHPS scores goes, to take that extra step and to bring your services to your members where they're at when they need it.
Stuff. I have don't move because I have 2 follow-ups for you. One
Okay.
planned, one unplanned. So don't.
It's okay.
And also, why don't we throw in, as I'm watching my production team work their butts off, throwing notes into the chat, which is one of the things we want your feedback on. Is this worth it to helping your experience? Why don't we throw that survey into the chat? If you haven't taken it already, it'll be showing up in your inbox also in 2 minutes. So, Stace, actually, you're describing what a strong experience feels like and how you guys know your members, their members are familiar to you, it's consistent, and the consumers who are part of your health plan, that's the difference. So first, I want to take a quick segue here because the challenge of doing this consistently across the member journey involves, like what Stacy and everyone else is talking about, not just those individual moments. And so if you need support in how to do that, how to make that hum, that's where technology comes in, where MedOrion could be a big help because most plans are just trying to reach the members, where MedOrion is helping identify them and then actually figuring out which ones are movable, engageable, and what it takes to have them influence them and change their behavior. And they do this by combining clinical, situational, behavioral signals and data points to understand not just what's happening, but connect it to why the member isn't acting and what's most likely, again, to move them forward. So that's something you're thinking about. If you just want to be able to rethink your strategy and know the options out there to make a more of an impact in your member journey, I'm happy to connect you with Dave. He's got the better part of 25 years. Dave, correct me if I'm aging you too much, at health plans, a lot of this. So if you want to just
A lot of years.
say it again.
Yeah, a lot of years out there.
A lot of years. Put a poll and I'll make a warm intro so you don't have anyone coming at you. If you want to meet Dave offline and just talk about this stuff. So Stacy, I want to bring you back for 2 questions. I wasn't going to do this because we're a little bit behind schedule, but this is such a great question from one of our audience members. So they've been exploring alternatives to CAHPS as it relates to quality incentives such as HEDIS and PCOMs. And she wants to know how you and your fellow panelists, so people could jump in on this, although I won't make this go too long because we are getting behind. She wants to know, your thoughts on the challenges and opportunities you see in expanding beyond traditional CAHPS reporting, and if you have any measures that you've adopted already to improve actionability. Like I heard you dropping kind of flu as one, but like, even though you can't totally drop it, but you're kind of,
I know.
I say punting on it. But like, what about ones that maybe you should be tracking that aren't being dictated to you that you guys are?
Well, to be honest, we track every measure. We're constantly using our data and analyzing it and really seeing what we need to focus on. And when we do that, I have a great team that works together, that brainstorms, and we're looking at those solutions that are really member centric. And that's what we try to focus on. How can we find a solution that the member is going to agree with, want to increase their health, and really we really work a lot with our providers. It's really the provider partners that are key into helping drive a lot of members to get their health improved, because most of our members are going to listen to what their providers and their PCPs say. So it's really a multi-prong approach that we're using to get all of this completed.
Got it. Got it. And is that, it sounds like when you're talking about understanding the members and then taking those struggles that they're having and actually translating them into action, it starts with the provider.
Well, it starts with the provider if they identify it, but provider's a piece of it. If we can identify the problem, then we can work with the PCP. We can work with maybe our community APRN or our case managers, and we can bring in those pieces that our members need. If they're homebound and they can't get to their PCP, we've got our APRN that's working with the PCP, communicating about what needs to get done for that member.
Got it. Perfect. Okay. 13 minutes. We're going to see what we could do here. I'm going to jump around a bit, but I think we're going to be able to get through this. We have a lot of good stuff coming up here. So Dave, I'm going to bring you back in, and where do you most often see plans losing momentum once the members are already in the plan? And what have you actually seen work to keep the experience moving in the right direction?
Yeah. Great question. And a lot of this ties back to what Dan and Stacy and Paula were talking about around the navigation. But I think the first part is really all around the post-enrollment, right? So folks sign up, they get in, or they stay in, and now things kind of disappear. It's kind of quiet. Nobody guides them through what's going to happen next. So, first you got to start with that right momentum and help clarify with that member how it's going to work, right? Really the coordination of benefits that are out there, and eliminate the confusion. Benefit misalignment needs to make sure it's out there. And I think the big thing that we heard about here from Dan, Stacey, and Paula was really the navigation. And I kind of call it, there's outreach, right, that happens, and then there's a navigation side. And what this really comes down to is continuity, right? And the meaningful difference between outreach and navigation. Outreach to me is somebody communicating at the member, right? Go do this, go do that. Navigation is communicating and walking alongside the member, whether it's a facility, whether it's the nurse going to the home. Plans doing it well aren't really executing more touch points. They're not sending more communications. They're really sending and really executing better connected ones. And whether it's the first communication where it's talking about what your coverage looks like and what to expect from the plan, or whether it's, throughout the year in terms of how it works through. But, navigation, I think, is a key, and it's got to flow across the system to work well. So, and I think that's another, important piece that where folks kind of lose some of the momentum is that the navigation doesn't flow, right? It's got to connect with all the different areas of the business, whether it's stars, whether it's case management, whether it's your pharmacy, whether it's the folks on the street. That has to flow across the overall system. And there can't be those, silos at the end of the day. The functions have to work together. I know a lot of plans have been focused on coming up with that member 360, right? Which highlights all of the data for that member. But that's where plans have got to continue the momentum and drive that overall communication. So the one shared view of the member across all the functions, the coordinated navigation logic that determines, who needs to lead at what moment, whether it's stars, whether it's pharmacy, that continuous feedback loop, and then the shared accountability for the member experience, right, at the end of the day, and not just a metric that each team owns. And where we've seen plans that maintain the momentum, have a very clear sequence of events for the first 60, 90 days. They anticipate where that confusion is, most likely, whether it's the benefit design, whether it's the coordination and getting ahead of it. They are sharing member data across all the different areas of the business. And, last but not least, right, to what Stacy was saying is keep your provider informed, right? Health plans have the most complete data set about the member at the end of the day. So share it, right? I mean, you could be going into their home seeing a lot of different things. You're seeing all the different care that member is going through, whether it's through the PCP or specialists or urgent care or, ED visits. Stay coordinated with those providers and drive that care coordination at the end of the day. So
This
those have got to be the key elements. Yep.
Basically, to summarize, it comes down to how everything connects behind the scenes.
Yep.
And so,
Right.
Paula, let's give us the blueprint. So what does it take to coordinate all of this across the entire organization in a way that, creates a great member experience?
Yeah, and Dave alluded to some of it, but as he said, probably the key is to making sure you have that commitment and support across all levels of the organization, with security health plan and many folks on the phone probably being from provider-owned plans. Critical to have that system. Stacy mentioned that, to have the provider support, and so when recently we've implemented some programs for social services network, and it was critical to have folks at the table from all of those. The saying used to be quality is everybody's business, but really member experiences too. And I know that's kind of cliche, but it takes all of the departments within the plan and the system, and having that dedicated leadership, project management support, and so working together to become aligned. As Dave said, making sure that it's not all of these separate outreaches, but really looking at that member in terms of the 360. Anytime we can do co-branding, making sure that there's data sharing between the provider system and the plan, really close linkages with the case care management, making sure that we're looking at the trending in the dashboarding with our social services network that we implemented. It's been really nice because we can enhance that platform as the case managers are working with those members, and that it's now helped us to really identify additional opportunities, being in a rural area, identifying additional needs. So from a member's perspective, it's been very seamless. So just really looking at that, kind of all those keywords that Dave said, that collaboration, the commitment from leadership, the dedication, and not looking at it in terms of trying to improve this single measure, but really having the goal of creating the best experience for the member.
Good stuff. I think that level of coordination, when it actually comes together, it's going to change the culture of the organization and the entire experience that the member feels as a byproduct of that, or a product of that, I should say. I'm going to have our physician close for us, although if we have some time, I have a couple of questions I want to throw in from the audience too to close us out. So we'll see where we go here. But Dan, I'm going to bring you back in. And if you take everything that we've talked about today, I'm sure you've been taking diligent notes. Where have you guys actually learned as an organization and said, hey, this is where we're going to double down and focus? And what has that changed at Emblem and how you operate and how members experience the plan?
Yeah. Well, my colleagues have repeatedly talked about the importance of medication and pharmacy. And so we acknowledge that, first of all, it's a big cost driver and a driver of trend, whether it be GLP-1s or gene therapy or just, polypharmacy, but the member experience is just so critical. So the pharmacy benefit is the most commonly used benefit. 6 in 10 adults are at least on one chronic condition medication, and 4 in 10 are on 2 or more. And so what we did was we migrated away from a legacy PBM to a more sort of cutting edge model. And so we just went live 2-3 months ago. It was a bit of a Herculean effort, but it was definitely worth the lift. We implemented a modular PBM pharmacy benefits program using Prime Therapeutics, Capital RX for the adjudication platform, Free Market Health, which allows a tremendous amount of flexibility and which specialty pharmacy will adjudicate and dispense specialty medication, and Amazon Pharmacy for mail order. And we have a much broader network as well for the brick and mortars in New York City. And so really the intent there was to bring best in breed capabilities across the pharmacy benefits space to elevate that member experience and use just more cutting edge technology. And so we just went live. And what I'm particularly excited about is not only sort of the better member experience, but bringing together both the digital tools and capabilities of Prime and as well as Amazon Pharmacy. And really the idea here is just afford more flexibility and choice for our members, but also being able to coordinate that at a member level. So we're off to a really strong start. And I think sort of where we're headed next is working with hospital-owned specialty pharmacies who know their patients very well and allowing us to coordinate care with those hospital specialty pharmacies to sort of unlock even more personalized care. And so we're having a number of conversations with some really impressive specialty pharmacies across New York City, and so that's sort of the next wave of innovation that we're embarking on.
Great way to almost close us out. Good stuff. We're really tight on time, so I'm gonna take a couple of questions that are quick answers that some of our audience wanted to learn about. I'll start with you. I think this was you, Dan, but it may have been Dave. What was the timing for the ANOC outreach campaign? Was that you that discussed that, Dan, or was it Dave?
That was Dave.
Dave.
Yeah, timing was fourth quarter, right, to get ahead of it, as well as then first quarter, right before the member was going to use the benefits. So fourth quarter, first quarter.
Okay, follow-up for you then, Dave. Have you looked at integrating loneliness severity and persistence signals since it's changed how people kind of receive messages as a driver for disengagement, non-adherence, all that?
Yep. We have, and we can get into a lot more detail on that if anybody wants a separate session outside of this, but yes.
Okay. And Dan, I think this is for you. Do you personalize your communication or your strategy tied to disengagement risk? And have you integrated like additional analytics into your personalized engine?
Terrific question. What we're starting to do is be a lot more data driven as it relates to the contents of the conversation. So we're going to be applying AI to summarize conversations and look for themes, unmet needs, and then pull that forward into opportunities to close gaps of care. Also, what I think is really exciting is the ability to listen to sort of intonation, voice, speed, and potentially identify mental health conditions that we can address more promptly. So I think in the era of agentic AI, we'll be able to apply a lot more technology into these conversations and really augment our capabilities in care management.
Perfect. That's a wrap. I'll summarize for everyone with this. Most plans try to improve their scores. The better ones design the moments that create it. And I hope for everyone listening, watching, wherever you may be, we know your time is valuable. We truly appreciate you spending an hour with us. We hope that this was worth your time and super valuable, and you'll be back with us. I want to shout out, thank you to our 4 incredible guests. They put a lot of time and for preparation to make sure that their answers were concise and valuable for all of you. So I thank you, all of you, for doing that. I know this is not your day job by any stretch. Speaking of day job, it is Nicole Roberts' day job, our producer, but she did a great job producing this episode. So hats off to her as well. Thank you, everyone. Until our next show, remember, this is your Bright Spots in Healthcare podcast. Take care.
Thank you.